The following presentation is funded in part by Centerstone. Hello, and welcome to this communication educational session on the impact of COVID-19 on brain health, presented by the Brain Health Initiative on behalf of Centerstone. I'm Dr. Shelley Carson, a scientific director of research at the Brain Health Initiative, and also a psychologist, researcher, and lecturer at Harvard University's Department of Psychology and Continuing Education School. This educational session will be presented in 3 segments, addressing neurological symptoms and complications of COVID-19, mental illness symptoms and their prevalence during the COVID pandemic, and finally, steps we as mental health professionals can take to improve overall brain health and wellness in our own lives, the lives of clients and patients, and others in our community. Thank you for your interest in this topic. In this segment, we'll examine neurologic symptoms that are associated with SARS-CoV-2, the virus that causes COVID-19 infectious disease, and the implications of these symptoms for patients and mental health professionals. Neurologic and central nervous system symptoms have been identified in a substantial percentage of COVID-positive patients and may be present even before the onset of more classic symptoms. Neurologic and CNS complications also may accompany the COVID infection, and neurologic CNS complications may develop as a result of COVID infection days, weeks, or even months after other signs of the infection are no longer present. Studies estimate between 38% and 82% of all hospitalized COVID-positive patients display neurologic symptoms. It's important for the mental health community to understand these neurologic signs and indicators, as they may be confused with, occur comorbidly with, or cause or exacerbate symptoms of mental illness. Let's look first at the neurologic symptoms that may precede the onset of typical symptoms. The classic indicators of COVID-19 infection include respiratory symptoms of fever, shortness of breath, cough, and fatigue. However, by spring of 2020, it became apparent that a substantial percentage of individuals with cases of the virus were experiencing neurologic as well as respiratory symptoms. The most common among these neurologic symptoms included anosmia, or loss of sense of smell, ageusia, loss of sense of taste, headache, muscle pain, dizziness or incoordination, difficulty concentrating or mental confusion, and difficulty waking or staying awake. We know these symptoms can occur up to several days before any respiratory symptoms are noticeable. In general, but not always, the presence of neurologic symptoms is associated with more severe manifestations of the virus and should be reported to a medical professional immediately. However, each symptom is complex in its own right and deserves a closer look. Anosmia, loss of sense of smell, is also referred to as olfactory dysfunction by researchers. For perhaps 11 to 27% of COVID-positive cases, olfactory dysfunction is their first indication of COVID infection, and it can manifest as many as 3 days prior to classic respiratory symptoms. In fact, according to some investigators, anosmia may be the better predictor of coronavirus than any other symptom. All told, the research suggests between 40 and 85% of patients who contract the virus will experience some degree of olfactory dysfunction. There's debate about what causes anosmia in COVID-19. While this novel coronavirus has the capacity to enter the central nervous system through the olfactory bulb and olfactory neurons, in most cases it is support cells around the olfactory neurons that are affected. That's good news for patients because if the olfactory neurons themselves are not damaged, in most cases the sense of smell will return completely or almost completely. In many cases, anosmia may also be the result of inflammation as the body seeks to defend itself against the virus, in which case the loss of smell is similar to that experienced with the common cold or flu. Again, in such cases, patients can expect a complete or near complete return of their ability to smell. For patients who do not experience a resolution of this symptom within several weeks after the infection is cleared, olfactory training is a reasonable treatment option and should be considered because of the side effects of unresolved anosmia. Clinical trials have shown that it's effective in improving olfactory function. Anosmia has been associated with depressive symptoms in the past. So it's important to monitor this symptom in patients and to reassure patients of the likelihood that olfactory functioning will be restored post-COVID. Ageusia, or loss of sense of taste, is also called gustatory dysfunction by researchers. It's tied to anosmia or olfactory dysfunction, but it's not as prevalent. According to a Mayo Clinic study published in August of 2020, the prevalence of gustatory dysfunction in COVID-positive patients was 38%. Again, the loss of taste is almost always simultaneous with the loss of smell. These two symptoms may have profound implications. Even prior to COVID, studies had found loss of these sensory modalities were associated with depression and anxiety, especially in seniors. A multinational study by Speth et al., published in November 2020, found that of all the major symptoms associated with COVID-19, only the loss of smell and taste significantly predicted depression and anxiety symptoms in their study of 114 COVID-positive patients. Muscle pain or myalgia is another symptom of COVID. Surveys estimate that between 14 and 36% of COVID-positive patients experience muscle pain. Further, the incidence of myalgia may be more prevalent in the newer strain of the virus that's coming from the UK. While muscle aches can be the result of general fatigue, coronavirus-related muscle pain is different. It's real pain in muscles and joints and may feel like exercise-induced muscle pain. It results from damage to muscle fibers from the virus itself or from an inflammatory response within the body through inflammatory cytokines that are part of the immune system response to the virus. This can cause abnormal tissue breakdown. This type of muscle pain signals that the virus is present and may be at work in the peripheral nervous system. Headaches, dizziness, and confusion have been found to be prominent central nervous system symptoms as well. In a meta-analysis of 64 published studies covering 11,000 patients, Nazari and colleagues found that the most common central nervous symptoms reported, note that anosmia and ageusia were not examined in this review, were headaches at 8.69% and dizziness at 5.94%. Headaches pose a problem for researchers because their origin can be so varied. For example, Nazari et al. Point out that headaches could be the result of anxiety and stress over having the virus, as well as a result of the virus itself. And we'll talk about other potential causes of these symptoms in a few minutes. Another important symptom, though, is mental confusion. This symptom has been noted in as many as half of patients who are eventually hospitalized. In seniors especially, this symptom can be serious. The experience of confusion, a mild form of delirium, has been linked to greater risk for dementia later on. In a 2015 review of over 4,500 seniors, Fong et al. Provided evidence that a single episode of delirium can increase risk for dementia independent of other factors. Dizziness, confusion, difficulty staying awake, which we mentioned earlier, and possibly headaches, all can signal an alteration in mental status. These symptoms have been associated with more serious cases of COVID-19, and because they may appear before classic respiratory symptoms of the virus, they may offer an opportunity for early detection and an early start on treatment. If a patient presents with one of these symptoms or complains remotely of one of these issues, immediate referral for COVID testing could be life-saving. These neurologic symptoms we've been looking at may be evident before the onset of classic respiratory COVID symptoms and may extend throughout the infectious period of illness. These symptoms may also suggest that the novel coronavirus doesn't only invade the respiratory system, but may have implications for the central nervous system as well. Does that mean that the virus is actually invading the brain? Well, not in all cases where we see neurologic symptoms. The COVID-19 virus exploits the ACE2 receptor to gain entry into cells in human tissue and organs. Post-mortem and in vivo investigations have found evidence that the virus is in brain tissue, which may account for some of the more severe neurologic manifestations that have been observed, but actual invasion of the brain may be relatively rare. The coronavirus has two main routes of entry that can lead to central nervous system infection. One is labeled the hematogenous route. Here, the virus infecting respiratory tracts can reach the central nervous system through the bloodstream, where it overcomes the blood-brain barrier. In the second route, a peripheral nerve can provide the virus with a backdoor access to the central nervous system, for instance, through nerve terminals in the nasal cavity or even through the eyes. The SARS-CoV virus can also have indirect effects on the central nervous system, and this is likely how it does the most damage. The first is through respiratory infection of airway tissues by COVID-19. In severe cases, this may lead to impaired gas exchange, causing central nervous system hypoxia that results in neural dysfunction and/or neuronal death. The second is by triggering the overactive immune system response known as the cytokine storm. During a cytokine storm, the influx of pro-inflammatory cytokines produced by the body's own immune system attacks bodily tissues, including CNS tissue, leading to the neurologic complications. In many cases, it's difficult to determine which neurologic complications and symptoms are the result of which of these causes, the virus itself or the body's response to the coronavirus. This is the case with some of the neurologic complications that occurred during the course of the coronavirus infection. In addition to the symptoms we've already discussed, one of the most devastating results of the virus is stroke, especially ischemic strokes, which have been reported in clinics worldwide as a result of COVID. Neurologists at Mount Sinai Hospital in New York reviewed the rates of stroke in younger patients with COVID and initially found that they were elevated, even in patients without risk factors for stroke. However, a September 2020 review of studies in The Lancet reported that a rate of 2 to 6% of patients hospitalized for COVID had experienced stroke and that strokes were more prominent in older people and those with risk factors already for stroke. According to Harvard Medical School researchers, COVID-related strokes may be due to blood clots or to direct infection of the coronavirus, in which infected cells usurp oxygen from adjacent cells, leading to neuronal death. Encephalopathies, a catch-all term covering a broad spectrum of brain diseases, have been reported in conjunction with COVID-19. These conditions may respond to treatment and may be the result of direct infection by the virus or of cytokine storm. Severe neurologic complications increase the likelihood of psychiatric comorbidities. Among these are depressive, anxiety, and stress-related symptoms such as post-traumatic stress disorder. In addition, a British group reporting in The Lancet described a set of 10 cases of psychosis attributable to the coronavirus without any prior evidence of psychotic symptoms. These cases were captured through an online physician's reporting portal, and the cases appeared to occur across all age groups. Patterson et al. Reported a set of patients at the National Hospital for Neurology and Neurosurgery at University College London, where 10 patients with COVID-19 exhibited encephalopathies with a combination of delirium and psychosis. A vignette of one patient describes a 55-year-old female patient with no previous psychiatric history who exhibited anosmia and hypogeusia, and her husband reported that she was confused and behaving oddly. She reported visual hallucinations, seeing lions and monkeys in her house. She also had Capgras delusion concerning her husband and other systematized delusional misperceptions. Guillain-Barré syndrome is an autoimmune response to severe viral infection in which the immune system attacks and damages peripheral nerves, leading to paralysis, pain, and numbing of the arms and legs. Most patients eventually recover, some with lingering numbness or weakness of the limbs. This is a rare response to COVID, but the number of cases is mounting, and at least 19 have been reported in the literature. Guillain-Barré can develop even after a resolution of COVID symptoms, with most cases occurring within 6 weeks of infection. A subset of people who've recovered from COVID-19 will go on to experience symptoms that linger well beyond testing negative for the virus. These individuals suffer what's being called post-COVID syndrome. The sufferers are sometimes referred to as COVID long haulers. The symptoms of post-COVID syndrome may include fatigue, difficulty breathing, joint pain, chest pain, brain fog, which includes an inability to concentrate and impaired memory, loss of taste or smell, and sleep issues. Those who seem to be most at risk for developing post-COVID syndrome include older adults, people who experienced a more severe case of COVID, and people with underlying health conditions, particularly cardiopulmonary issues, hypertension, diabetes, and obesity. The long-term effects of COVID are widespread. An Italian study of 165 patients and a Chinese study of over 1,700 patients, both reassessing after release from COVID-19 hospitalization, found that 36% and 63% of patients respectively continued to have fatigue, memory and attention problems, anxiety and depression, and sleep difficulty, as well as other symptoms 6 months after release from hospitalization. research continues on the underlying causes of these lingering symptoms. However, it's possible that some of the patients with post-COVID syndrome may be suffering from PTSD. There may be many causes of PTSD in previously hospitalized patients. PTSD can be caused from viral infection itself and its effect on the central nervous system, or it can be the result of a neurologic event such as an undetected stroke. It can result from the trauma of ICU or hospital events, especially if other patients have died, and it can be the result of intubation and induced coma, which is a life-threatening experience. All previously hospitalized patients with unresolved COVID symptoms should be screened and, if appropriate, treated for PTSD. As a mental health professional, what can you do to lessen the impact of neurologic involvement in COVID-19? First, watch for signs of neurologic symptoms. The Brain Health Initiative has a neurologic symptom screener available if you'd like to use one. If appropriate, educate clients about neurologic symptoms so they can self-monitor for these symptoms. Emphasize COVID safety protocol. Clients with mental health conditions are at greater risk for COVID, as we'll discuss in another segment of this session. The best strategy for avoiding neurologic symptoms is to avoid the virus altogether. Keep in mind that many neurologic symptoms can look like symptoms of mental disorder, especially major depression. Difficulty making decisions could be confusion associated with mild delirium. Hypersomnia may be difficulty rousing. Psychomotor retardation could be an indicator of altered mental status. Many of these symptoms can be distinguished from depression by the suddenness of their onset. If any neurologic symptoms are detected, immediate referral for COVID testing is appropriate. Let's review this section on neurologic symptoms and responses. While COVID-19 is primarily a severe respiratory viral infection, we now know that it has implications for other bodily symptoms as well. Between 40 and 80% of COVID-positive patients have at least one neurologic symptom or complication. Anosmia, loss of smell, and ageusia, loss of taste, are common symptoms and are important to monitor because these symptoms have been associated with anxiety and depressive symptoms before COVID-19 and in a sample of COVID-positive patients. If patients display these symptoms, they should be monitored even after the resolution of the COVID virus. Olfactory training may be helpful in resolving these symptoms. Headache, dizziness, confusion, and difficulty waking or staying awake are altered mental status symptoms that may presage a severe manifestation of the COVID-19 viral infection. If patients display or complain about any of these symptoms, even in absence of respiratory signs, refer them for COVID testing immediately. The earlier they can be treated, the more favorable the outcome is likely to be. Severe neurological complications may increase the likelihood of psychiatric symptoms during and after COVID infection. The most common are depression, anxiety, and stress-related symptoms. It's possible that if you have patients who have suffered severe COVID infections, they may not have been screened for psychological symptoms and may need screening after they eventually test COVID negative. In addition, CNS-related complications have included delirium and psychosis, directly or indirectly attributable to viral infection. The neurologic and mental health effects of COVID-19 do not end with the resolution of respiratory symptoms. Symptoms may linger for months or even develop post-infection. Patients may need mental health support to deal with these neurologic effects in the aftermath of the virus. Because of the generally more severe effects of neurologic involvement, being vigilant for neurologic signs and referring clients for testing at the earliest suggestion of symptoms may significantly lessen COVID severity. A complete list of all references cited in this segment accompanies this presentation. For more information on COVID-19 and brain health, please see these additional videos in this communication education session. Thank you. I'm Dr. Shelley Carson.